And it's good. We only lost like 10 minutes on our planned timing. So we'll continue right now with a lecture from a speaker who is here for the third time. He was here for the very first summer school. He was here for the second time last year. And yeah, he is here again. And some of you who've been here last year or who've seen the video on YouTube might remember that last year's talk ended up with him taking off his shirt and being ultrasounded live while explaining anatomy. So, well, we'll see how it ends this year. And yeah, I'm very pleased to introduce to you Privatdozent Georg Feigl from the Medical University of Graz.
Okay. Goodness. Okay, thank you very much for this wonderful introduction. I'm really honored to be over here the third time. First time was, fortunately, I didn't listen to that. First time I was too late, I think about 40 minutes. So I was called during a workshop and then coming to the university. And the second one was a little bit more prepared, so third time should be better. And I really hope I do not bore you that much because it's anatomy. You know, anatomy is always like a little bit dry. Ugh, you know this, especially systematic anatomy, just like studying a telephone book, almost like that. In this kind, it's a little bit different because you need to know a lot of topographical anatomy, which is absolutely entirely different to that what you regularly study out of the textbooks. And this presentation, or let's say lecture, will be given to you very much focused on this special topic, not as last year, because last year I focused on the abdomen. This year I want to focus a little bit on the heart and more on the pelvic area. So if there is some time left, we'll take a look also on the upper abdominal part, but this year I want to start with the heart. So everybody who's interested also in the upper abdomen should go to YouTube. So it's a little bit for everybody. Unfortunately, for those who are only speaking English or Spanish or other languages, it's in German and with a very, very bad accent. So excuse for that. Aim for my English over here too. It's a little bit different. You know, the students have a very bad accent also. You know Arnold Schwarzenegger, especially with his accent. Oh yes, that was a wonderful day. I'm not talking like that, hopefully. Okay, let's start with that. So you don't need to draw everything. I already sent the PDF file to Sono for you, so they will keep it and give it to you, so you can download it later on. So you don't need to draw this, but more or less you have to follow it a little bit. Okay, and oh yeah, working. And in case, of course, if there is any question, just interrupt and say, well, I have a question. So tell it to me then. Yep, that's it. Okay, let's start. Heart. I will write it in Latin. Nevertheless, I will say it. Okay, good. Core. Wonderful. Can everybody read this? Feedback, please. Yes. Very good. Okay, the core, heart. Of course, it's positioned in the mediastinum. So you have the anterior inferior mediastinum, and it's also in the pericardial cavity. So let's write it down. Cavitas pericardialis or pericardiaca, which means pericardial cavity, of course. We have different components. You have the pericard, you have also the epicard. You know the epicard is the part, the serous part of the visceral layer of the pericardium serosum, the serous pericard. Anyway, the heart itself on its surface has different parts, and these are the main important ones. So we have to take a look on the so-called fascias of the heart, facies, the faces of the heart. And this is a very important thing, because without the faces, you cannot section the heart by ultrasound. And you cannot get an idea of the different images, what you will get if you make the ultrasound investigation. So, which faces do we need? The first one is the very most important one, which is the ventral part, or sternocostal face, facies sternocostalis. Quite clear, it's facing, or it's just in the back of the sternum and the ribs. Sternocostal surface, or face. The second one is one which is going caudally, which means it is just in opposite of the diaphragm. Therefore, it's the facies diaphragmatica, or diaphragmatic face. The third one is going posteriorly, which means, it's going to the back, in direction of the vertebral spine. Anyway, of course, there is something in between the spine and the heart itself, which means you have the esophagus and, of course, also the thoracic aorta. Nevertheless, it's the posterior face, facies posterior. Quite an interesting challenge to write everything in Latin and tell you about the English terms. So I apologize for something which is not written correctly. And of course there are some others which are facies lateralis, so the lateral face. Lateralis. Yeah. So let's make a drawing of that. When we just take a look on the heart with the ventral aspect, which means we take a look on the sternocostal face. So, you got over here a large vessel coming down, and then a little bit bumpy to the right side. Small vessel going down over here, and you see something like small little ear. Not mine is a little bit with a peak in there, so almost a Spock. I kind of do this with the fingers. So. And then it's going a little bit like a curve upwards again. You see over here, this is one of these major components. So we got now the right part, the right side of the heart, which means you have the atrium, the right atrium, atrium dextrum. Of course, entering from caudal, it's the inferior caval vein, and coming from cranially, you have the superior caval vein, vena cava superior. So both are entering the atrium. And you got, of course, Small part over here, this is the auricular. Okay. Then, from the atrium, it's going to the ventricle. Ventriculus dexter, right ventricle. And then, following to the pulmonary trunk. I know you all know that. You got this someday in the lecture. But you will see that's one of the major components afterwards, because then we're doing the cross section. So take care. I know it's very late, also on Friday. Regularly you should be somewhere else. Yeah. Center of town drinking good electrolyte beer or something like that. Later on maybe. So you got over here pulmonary trunk going to the left pulmonary artery. Okay, now I'm English. Okay, pulmonary artery, arteria pulmonalis sinistra. So just beside, more on the left-hand side, you have a part of the left atrium, atrium sinistrum, which is the auricular again. This is visible on the sternocostal face. And then it's going into the left ventricle, ventriculus sinister. Left ventricle, which is forming the apex cordis, or apex of the heart. So, what is missing now? Well, if you got the ventricle and the pulmonary trunk, the aorta is missing, and the aorta is just in between the pulmonary trunk and the supracaval vein. So you get over here the ascending aorta ascendens, ascending aorta. So you see, you got a problem over here that you get two vessels which are crossing each other, or let's say two parts of the heart crossing if you just take a ventral aspect. The first one is more dorsally, which is the left part of the heart, and the part of the left ventricle is crossing behind the right ventricle. And this you have to take into account, into consideration, when you will use your ultrasound probe, because then you get the topography of these parts of the heart. So, where is this now? In the area of the thorax. Just take one image out of Prometheus. Fortunately, we are allowed to do this because we have this special, let's say like that, CD in our department where we can make some copies out of it. No copyright on that, fortunately. So there's no problem with it. And anyway, you get over here, this is now the right atrium area. And now, on the other hand, you see this is the heart, the shade of the heart. You will get the shade of the heart. But you will never get an image of the atrium, for example, right atrium behind the sternum. It's not possible because this is bone. So what you have to take, to take the intercostal area, the intercostal space, to put your probe on. And this is the area where you get the probe with the sector scan going dorsally. So this is a very important thing. You have to take always into account where your probe is. So what you can see at the very closest part of the thorax, of the thoracic wall. And this means if you take, for example, the probe in this intercostal space, what do you have at the very beginning? Of course, something which will cross like that, which means it's the right ventricle going up. So this is the very superficial or most superficial part of the heart in this area where you get your sector scan on. Take this into account always. You will never see the right atrium at the very closest or nearest point by the probe. That's the farthest away point, which means this is a very important thing. If you get into the left side of the sternum in the intercostal space, you always will see one ventricle. And the first ventricle you will see, as close to the probe as possible, will always be the right one in this area. So let's take now these fascias again, the faces again of the heart. I want to make now a little sagittal section of the heart, which means a little bit like that you have over here the heart with the different parts, and over here again this is the aorta going up, and this will be a little bit the right atrium. Right atrium, then you get ventriculus dexter, the right ventricle. Over here going up the aorta. That's good. English same as in Latin. Perfect, no problem. The aorta, the ascending aorta over here, and the left ventricle will be a little bit more dorsally. So what you get over here, this is the sternocostal face, facies sternocostalis. Again, this means you get over here, just take a look up to the screen, this way, this is ventrally. So there would be the thoracic cage, just ventral to it. This is the thoracic cage over here. So you get the right ventricle and the first, if you put the sector scan on. We make it just with a second attempt. Then the diaphragmatic face, facies diaphragmatica, is always more caudally, and one major component over here would be the left ventricle, ventriculus sinister. And then you get the final face, which is the posterior face, facies posterior, and you see, oh, over there should be the atrium, especially the left atrium, atrium sinistrum. So you see already, this is one of the major tasks concerning your sector scan or your sectioning. So let's make the next image about that. We just go up a little bit. We get now one rib, and we enlarge now the intercostal space a little bit. Get a better image. Oh, it's okay like that. So you get two ribs. So costa, ribs, and the intercostal muscles. A little bit dorsally to it. Let's make it like that. Over here, again, you see the heart. With the sternocostal part going up over here to the area of the left pulmonary artery. So what you have over here is a sagittal section with a view of the left side to the right side. So left side view, and we are cutting the heart sagittally. So arteria pulmonalis sinistra, left pulmonary artery. This would be the right ventricle, and up here would be the right atrium. So more or less supracaval vein. Again, already sectioning over here the left atrium, atrium sinistrum, and the left ventricle, ventriculus sinister. But now we can take the aorta into account. So the aorta is just running like curved dorsally, which means the aorta has to pass the right ventricle in this manner that you have now striped lines of the aorta going up. And you see? That was a bottle. Hopefully not a beer. Okay, back to the left atrium and then to the left ventricle. You see, there is one part of the left ventricle passing dorsally to the right ventricle. And this has to be because of this topography, as I told you before, that you have a certain topography of right to left ventricle. So this is a little bit turned around, which means if you have the right ventricle, the left has to pass in a turned way dorsally to reach the final exit area at the cupola of the heart. So again, left ventricle going up, this would be the aorta. This is something what you can see later on. Because if you take now the probe, let's put the probe up here, sector scan. You see, that's almost linear, but as you already heard before, if you investigate the heart, it's not a linear scan, but more a sector, which is produced. And therefore, the sector scan would be now like almost that. So this is your scan, what you get. It's the plane out of it. This is what you see then. And what does this mean now? If we make really this cross-section, let's make this image again, but really by sectioning. This is more a hybrid image, which means you see the surface, still the lateral one, but over here that there is something which is really turning. So let's make another image about that. We start again with the ribs. So, first rib, second rib, intercostal muscles, of course. And now the heart again. We make now the right ventricle. And now you see already a little bit the myocard. And you know that the myocard of the right side is not that thick as in contrast to that the left side. And you get now the apex of the heart and huge thick myocard of the left ventricle. So this is really the impression now of the sagittal section, what you get of the heart when you do this sector scan. Moreover, you find over here the aorta going up and the left atrium over here. So this is the atrium sinistrum, left atrium. This is the aorta going up, and in between, of course, you have the left ventricle, ventriculus sinister, left ventricle. And as I told you before, the first part you see in your sectioning is the right ventricle, but only the right ventricle, no atrium in this section. Which kind or which parts of the ventricles do you see? Well, in the systematical anatomy, you learned about the inlet area and the outlet area. The inlet area is reached by the atrium. So it's the entering blood into the ventricle. The outlet area gives the blood to the following vessels, which means right side it's going to the pulmonary trunk, on the left side it's going into the aorta. That's the outlet area. If you have this cross section over here, this would be followed by the pulmonary trunk, which means you get over here an O for outlet area of the right ventricle. But on the left ventricle, you see both. You got the atrium over here, and of course in between atrium and ventricle you have the mitral valve, valva mitralis, with two cuspides. So you got two wonderful parts of the valve, which is the posterior one and the ventral one. The ventral one, you know, it's called also cuspis aortae, which means it's just between the inlet area and the outlet area of the ventricle. So you see both of them. And you could also see if the section is a perfect one, certainly the aortic valve. So you get both valves in this area. The aortic valve, valva aortae, and the second one, the mitral valve, valva atrioventricularis sinistra. Sorry, that's the anatomist in me. Mitralis. Also perfect. And this section you will see, but this is the long axis. Oh God, long axis, short axis. What does this mean? You already saw this with the esigurgal. Yeah, you can cut it in the short way, cross section, and the long section. Then you get the long esigurgal. Yeah? You can do it with everything. Yeah? Not only with the esigurgal. That sounds cool. I wonder if everybody in Texas will understand esigurgal. But what about Germany? Herr Lechbaumer? Okay, don't hear us. Esigurgal. Okay, let's make now a cross section, and then we take a look on the real images what you have in, for example, your Sono4U script with the ultrasound images, what you already saw, if you have studied it. So let's make now a cross section. A cross section is like that, now that you have over here the intercostal muscles. You got the sector scan, of course. And the first part, you see, is something which is a little bit thinner. Not very much myocard in that area. And then you get huge space, lot of myocard in this area. It's not Frosty the Snowman. And sometimes you can also see over here something in between, which would be one of the valve parts. So valva mitralis. This is part of the valva mitralis, which means, of course, you got over here the left ventricle, and this is the right ventricle, just in front of it. So where's your probe now? The probe would be over here, and you got this scan. This is your scan area again. And this is what you see. even partially you see these valve parts, and if, again, the scan is in the right sectioning, you might also see the papillary muscles. Over here, musculus papillaris. So you might see these two. Sometimes, if the device is absolutely a perfect one, what could you also see in between the papillary muscles and the valve itself? The tendinal cords. Yes, the tendinous cords. Yeah, of course, corda tendine. This you also can see. Very good devices can show you that easily. And especially you are young, you will see the advance of these techniques, especially ultrasound. Also three-dimensional images what can be created already. But now with probes with 21 megahertz, you can see small, tiny nerves and structures huge on the screen. And this is something which is very, very difficult to understand and what you have to train on. And this is the same with the heart, as you see. You got all these cross-sectioning, these oblique sections. And without the knowledge of the topography of the heart, it won't be possible to recognize these. So let's take a look now on these two cross-sections. I want to talk about it directly. So what you see over here, and I put it now in the right area. Oops, like that. Yep. Just a moment. That's it. Over here would be the probe. The probe again. Let's make the probe over here again. And the sector scan. Goddamn. Other color. Sector scan. Yeah? Okay. And now let's let it correspond to the ultrasound image. What you see over here is the first, this is the right ventricle. The first hole. The second is the outlet area, number 2, outlet area of the left ventricle. Number 3, well, that's the ventricle, the left one. This is the inlet area of the left ventricle, and 5 would be the left atrium. And you see in between, that's the valve. That's the mitral valve. If you go up, you see already might be over here aortic valve. Yeah, a little bit, yes or no. So you should change a little bit with the probe, and then you could see this. So this is the scan what you get. And you see that's really corresponding now. Anyway, it's the sectioning what you saw before. And now let's go back to our first, oops, where's my first part? Just a moment. Our first image. So how would be now the scan? It would be almost like that. So this is your scan plane. Because with the probe, you can always insert it into the intercostal space. And the intercostal space is not horizontally, it's not sagittally, but it's more oblique. So you see, this is your scan plane, what you get, because of the intercostal space. Okay, let's go to the second. And you see, if we just put it beside, oops, other way, like that. Okay, you see nothing, huh? Okay, not very easy. You see, right ventricle, left ventricle. In addition, over here might be a papillary muscle. And you can see these structures already. So might be a valve, might be a, this would be more papillary muscle. As you see, the thickness, and it's the same hyperepogenic structure. So that's more corresponding to a myocard area as to the ventricle itself. Anyway, you see again, it's the sector scan. You see right ventricle at the first part, which would be the outlet area, and this is inlet and outlet, inlet in the dorsal part, outlet in the ventral part of the left ventricle. So again, for copying it, it's the right ventricle and the left ventricle. This is the outlet area, inlet area of these ventricular parts. As you can already see, oh, that's not easy. And especially if you have then the scan from the apex, which means you get, of course, all 4 chambers of the heart, which means both ventricles and both atriums. That's even more oblique. Yeah? So you have to go to the apex of the heart and then going straight with an oblique scan through the heart so that you can see all the 4 chambers on one image. Okay, that was the heart. Second, let's go to the pelvis a little bit. Last year was a little bit fast. Last final 10 minutes were about the pelvic area. Just want to continue with that too. So concerning upper abdomen, we make one drawing at the final part, and I would take now the part of the pelvic area, pelvis. So pelvis a little bit. And we start with female area. So what we make is now a sagittal section through the body. Take first part of here bony part, which is this symphysis. Then you get the plane of pelvic entrance, sacrum dorsally. So we can put now the skin area on. Let's see over here. Abdominal wall, skin going there, and dorsal part, and it's the limb, lower limb, not Lindsland, lower limb. Yeah. And sacrum is dorsally. Just for the scan, it's not a problem because you will never see the sacrum. Yeah? But for our cross-section or for sagittal section, it's very important. So what organs do you have in your section? Oh, abdominal wall, of course, going up. And you see already, oh God, it's very skinny. Would be lovely to have always patients like that. So what are you facing? You're not facing that many skinny persons, especially if you take a look on some other continents. Australia, somewhere else, a little bit where the body mass index is always increasing. Anyway, I just can stand up a little bit, you know. That's the real one, yeah, styrian. Abdomen, styrian pelvic area. So this is real, yeah, real life. Yeah. So try that. Of course, first you have to get more experience. Okay, experience is, of course, this is the training method now. Go to the devices, scan as much as possible, scan everybody. And then, on the list for Christmas time, please, one ultrasound device. Doesn't cost that much, only about 20,000, so not bad. It's on my list already, but, oh God, no Frank Stronach in my family, so I still have to wait for my machine. Let's go back to the pelvic area. So you see, symphysis. Then you get the bladder, urinary bladder, of course, not gallbladder, yeah, urinary bladder. Then we got a female now. Okay, uterus, vagina, going down, and the rectum. Finally. Yeah? Finally the rectum over here. Small rectum, but rectum. And now, what is more important, you get also the peritoneal cavity. So if you take the peritoneum going down, you see more or less over here a small groove in between the bladder and the uterus. Then passing along the uterus, going down, huge pouch over here, going up again. This is one of the most important pouches in the pelvic area. You get 2 of them. And you get the 1 and the 2. You see these 2 pouches over here. Or excavationes in Latin. And 1 is a pouch in between the bladder and the uterus. So excavatio. Vesico uterina, which means bladder and uterus. Perfect. But not the important one. Why? Because the patient is lying. And if the patient is lying, the liquid, any liquid, could be also an hematoma or pus or something like that, doesn't matter. So any liquid will go a little bit in here, but of course, according to gravity, it's going to the most caudal one. And in the lying position, of course, the most caudal one is number 2. And number 2 is in between uterus and rectum. So excavatio, that's the same. Rectouterina. And as something is very important, you get always a second name on that, a synonym, and that's the Douglas pouch, cavum Douglasi in Latin, or anything what you name. But you see, this is the Douglas pouch. So the most caudal one where the liquid is running into. And certainly now it's quite easy to get rid of this liquid which is too much in there. So you get already the excess of to get it. It's directly via the posterior fornix of the vagina. Just insert the needle, also with ultrasound guidance. You pass the uterus dorsally and you can puncture this peritoneal cavity area. So that's quite easy in this manner. If we take a section now, let's make it like that, this would be the image of a longitudinal section. But what do you see really? The problem is that you do not see the posterior parts, which means from that on, you just see hypodense, hyperechogenic images or signals. So what you see over here is the scan which is reaching the area, the level of this, the rectum, and nothing dorsally to it. So the very final part is the rectum, what you see. That's the rectum. But you see the pouch just in front of it. So ventral to the rectum, you will see the Douglas pouch. Anyway, you see also uterus and bladder. And this is one of the major problems. If the bladder is filled, you get a huge hypoechogenic structure in front. So you have to take this into account. Is the bladder filled or not? Because if the bladder is filled, it's not in this form, but more or less like a bowl. And the uterus is going dorsally, so the pouch will be a little bit closed then. But what is if we make a cross-section? So we got the scan over here, with the sector scan again. Oops. Sector scan again, like that. Problem is always the bone, so you have to go a little bit cranial. But what is if we turn it around? So let's make a cross-section of the pelvic area. You get the abdominal wall. This is a cross-section now. So what you get as the very first part in your ultrasound image is the bladder, which means you get the bowl of the bladder. Then you get pouch number 1. Partially, you might see the wall of the bladder itself. So sometimes you really could see the bladder wall. Of course, this is a thick muscular wall, as you know. Then you get the first pouch, sometimes a little bit uterus, fundus, might be also over here, the area going to the ovarium, and dorsally you get the rectum. This would be the rectum, this would be the uterus, and this would be vesica urinaria, so the bladder. And the second pouch is this area over here, what you see in the ultrasound image. So this is pouch number 2. So the best visible and most caudal part of the peritoneal cavity. Again, hyperechogenic structure is for here quite well visible. So this will be your border in the dorsal part. Okay. How does this look like? And let's make it over here. Let's go to this image. This is now the area. It's pretty dark anyway. If you know the script, you see over here in this plane, hyperechogenic structure. This would be now the Douglas pouch. Over here, hyperechogenic structure with the rectum in this level where my red pencil is now would be the rectum, and lateral to it the mesorectum with all the vessels coming along. Anyway, this is hyperechogenic. So your liquid in the most caudal part of the peritoneal cavity would be over here. So this pouch corresponding to it. Ventral to it, this area, this level, would be the bladder. So this is a very important difference. If a liquid is in the bladder, you should not puncture it. It regularly has an exit, a normal exit, which is the urethra. Yeah? This should be used then. Of course, if you want to try your manual skills concerning bladder puncture, you can do this too. But you should tell the patient first, and afterwards maybe also the lawyer. Let's go to the other one. So this image. And over here you see the topography of it. So this would be the pouch now. Douglas pouch, rectum area, rectum level. And you see it's quite good corresponding with that. So the pouch is very going caudally, and this would be the level of the bladder up here. But you see, this is the hypoechogenic structures. It's not easy over here. It's not easy to follow in this area. So what about the male? Female is very important, as you see. What about the male? Does the male have something corresponding to it? Well, of course, we do not have an uterus, but we have a corresponding pouch. So let's take a short look on the male. Again, sagittal section, quite easy. Male is not that interesting. Oops. But again, sacrum going down. Abdominal wall again. Skinny person again. Going down directly. Oops, drop, drop. And bladder, again visible, of course. Bladder over here. Going down. Over here the pelvic floor, and then the rectum. So what about the peritoneal cavity again? Get over here the peritoneal cavity. Sorry, this is again vesica urinaria. Rectum. Get everything. Prostata, yes, of course, for everybody. You're too young for that. You're older and you get the problems, the first problems with your prostata. That's good. Then you know you're old. So, peritoneal cavity going down over here. You see again, it's the most caudal part. And now there is the pouch in between the bladder and the rectum. So it's the excavatio recto vesicalis, which means between rectum and bladder. So that's the deepest part. The problem over here is, of course, not a quite good access to this area, to this cavity part. And this is also the so-called Proust pouch. Proust. I hope I pronounced that well. Nicht the very Styrian way to say cheers. Proust. Proust! Yeah. I hope it's Proust. Okay, so that's this pouch, the most caudal part. And again, you see, concerning the image, if you take the sector scan and you do the cross-sectioning, you will have the bladder in front, then the pouch, and then the rectum. So just in front of the most hyperechogenic part in the depth, you have this pouch. So this is one of your, let's say, landmarks to get this pouch well visible and to have a so-called anatomically, topographically landmark on your way off the scan. Also, again, not easy, not that easy. So, finally, still have some time left. You know, at 9 o'clock we have to exit everything. So, it's like being a postman. At 9 o'clock I will drop it. But anyway, we'll be faster than that. So, no problem with that. Let's go now to the abdomen, the abdominal part. So I would like to start with the upper abdomen and with the peritoneal cavity, so cavitas peritonealis, and just make a short overview over the upper abdomen, the supramesocolic compartment. Just one drawing, because we need this for the sectioning. So you know, most important part on the right side, liver. Wonderful liver. In Munich, there would be some other liver to be drawn. Currently, and you got the stomach over here with the duodenum going down a little bit like that. Oops. You get the gallbladder over here. The capillaris. And of course the spleen, lien. Nice little color over here. This is the systematic overview. Yeah? And then what you also get is, of course, colon. Colon going up over here with the flexure over here going down. Transverse colon. You know that the right flexure is a little bit more caudal turned to the left because of the liver. And then, what is also important, now striped, so not visible, in the dorsal area you find the kidneys. Kidneys are, of course, very dorsal to it. A little bit like a bean, but you see this would be the kidney, red, kidney, rain, brown, liver, hepar, stomach, gasta, all easy. Or ventriculus, then lien, spleen, and the colon. Okay. So what you get over here is now, you know that the transverse colon is a flexible part. You get a mesocolon, the transverse mesocolon, which is fixed at its root. And this cross line, it's really horizontal blue line, is the so-called root of the meso, which means over here it's fixed and you can move it up and down. And cranial to this line, you have this upper abdomen, or Oberbauch in German, or Drüsenbauch, where you find all different organs to, well, start, let's say, the digestion. No, I got it. I got them. That's always the problem with anatomy and physiology, yeah? Ooh. Never used this in English. Always only the organs. You see, I need this too. It's also for me very important that I get everything combined with. So also the physiology. Now, digestion starts over here, of course, with all the enzymes and the components to dilute everything. So, what about now the problem? Well, it's in the peritoneal cavity. So we don't have any idea what the peritoneal cavity is about over here. And one of the major problems is that, of course, with the topography of the organs, that the liver is just in front of the esophagus, that the stomach is a little bit on the left side, the spleen is very close to the ribs, so you get very different pouches in this area. And therefore, we have to make a cross-section, and just before that, we have to think about the pouches. So which pouches do we have? So-called recessus. So on the right side, dextrum, we got two of them, two pouches. One is the pouch just cranial to the liver. Recessus suprahepaticus. Or it's the same if it's underneath the diaphragm, subphrenic recess or pouch, subphrenicus. This is one which is very important if you have a hole in the intestine, for example, when air is getting into the peritoneal cavity, and you make, for example, an X-ray investigation, because the air is going into the most cranial part of the peritoneal cavity. Voila! You got the air in the subphrenic recess. That's a bingo. Yeah? Okay, 2. If we are cranial to it, it should be something caudal to it. So underneath, recessus infrahepaticus. But, oh God, you see there is another allocation because you can divide this infrahepatic recess into 2 others. The first one is in between the liver and the kidney. So, recessus hepatorenalis. Hepatorenal recess. Better known as the pouch of Morrison. And this is the one which you use for the ultrasound investigation concerning free liquid in the or too much liquid in the peritoneal cavity. So take this into account later on. The second one is a little bit more caudal. You see, this would be the hepatorenal recess, and just a little bit more caudal, you get a third organ with it, so it's the colon. Okay, recessus hepatorenocolicis. Hepatorenocolic recess in English. Okay, left would be the same, but more important, you got 3, the so-called lesser sac or bursa ommentalis. Bursa ommentalis is in English the lesser sac. And 4 is the splenorenal recess. So in between the spleen and dorsally would be the kidney. Recessus spleno or renosplenicus. Renosplenicus. So you see in between the kidney and the spleen. And this is the so-called Coller's pouch. So you get over here the name Koller. So you get 2 names, Morrison and Koller. Morrison is right, Koller left. Yeah? But where are they? And now we make one section, one huge section. This is the final section what I want to do, because I know after 1 hour, even more than 1 hour directly, of such an anatomy, we should stop. Yeah? So that you can get a little review on that, that you have to rethink about it. I don't want to say the real word for that, because you know this KSR. Yeah. Let's make a cross section. Horizontal section about that. And we think about the recess. So, get over here. Lumbar spine. And you see the lumbar spine is really huge going ventrally. So you get this peak, this bump over here, which is the spine. Just in front of it, you get over here the aorta, the vein, inferior caval vein. I don't want to focus on the vessels. Again, if you want to have your vessels, please go on the YouTube video, because we talked about that one more than 1 hour last year. So really just focus on that if you just need all the vessels. Now the kidneys. Which color? Oh, anyway, doesn't matter. Kidneys, any color. Kidneys. Both kidneys over here. Of course, they are in a cross section, not longitudinal section. Then you got the liver, dark brown, the liver. And now, something which is very important for you, please leave some space in between that we also can color with the blue, the peritoneal cavity. Regularly, as you will see, one of the images, there will be not that much. So that's the liver, hepar, again. Dorsally, that's the kidney, ren. Then we need the stomach in gray. Very dorsally, the spleen. You know that it's regularly in between the area of the ribs. 10th, between the 9th and the 11th rib. So if you have the ribs over here, you see also over here the ribs. That you can go in between the intercostal spaces to see then the pouches, as you will see later on. Then one organ, which is also very important, pancreas. And the pancreas is not only like that, but it's going more or less in direction of the spleen. And it's reaching the spleen itself. So that's the spleen, leon or spleen. And orange now the pancreas. Pancreas. And gasta. So now we have everything. Nevertheless, still missing the peritoneum. So what you need now is the peritoneum in this area. We start with the parietal peritoneum, which is following the abdominal wall, turning around just in front of the kidneys, going over here and reaching the aorta. Also on the right side, turning around, crossing the kidneys ventrally, reaching the inferior caval vein. But you know that the organs of the upper abdomen are intraperitoneal located. That means you get a meso. For the liver, from the ventral part, you see the ventral meso to the liver, mesohepaticum ventrale, and you know, oh God, it's starting again. Going dorsally. And I want to stop over here and close it like that. Say, that's wrong. No, just a moment, just a moment. Let's go to the pancreas, dorsally, you see. It's going over here, just ventral to the pancreas, dorsal to the pancreas, reaching the spleen, turning around the spleen, getting a meso again, connecting spleen and stomach to each other, covering the stomach, going over here again, and then getting brighter in this area for a structure which is connecting the duodenum and the liver, the porta hepatis. And this structure is the meso, or let's say a ligament, which is the hepatoduodenal ligament, where you get several structures in there. And you know all the three of them, the main structures, which is the biliary duct, ductus choledocus. Then you get the hepatic artery and the portal vein dorsally to it. So you get all the different structures. So this is the hepatoduodenal ligament, a meso, which means double layer of peritoneum. And a connection in between the parietal and the visceral peritoneum. And you say, oh God damn, that's all these different words. That's not the most important thing. The most important thing is coming now. You see now this cross-section, but the peritoneal cavity with the lying patient again, and the most dorsal parts of the peritoneal cavity where the liquid will be collected. And now you see these pouches. So where are your pouches now? Well, if you go to the right side, you can see in between hepa, the liver, and the kidney, you get one pouch. So this is, I have to go back. It's not the suprahepatic. The suprahepatic recess would be the one over here. This is number 1. Filled with air, again. Number 2, the infrahepatic recess, especially the hepatorenal recess, is this one. So the Morrison pouch would be in this area. And this is the area where the liquid will go to. Did you check this? Hopefully. The problem is now, where is the liquid coming from? Well, the liquid is coming from, of course, ventral part of the left side, but more or less, especially this huge cavity which is dorsally to the gaster, to the stomach, and in front of the pancreas. And this is the lesser sac, which means bursa ommentalis. So this is number 3. So, what liquid is in there regularly? Not much. It's a peritoneal cavity with a little bit of serosa in that, that's it. But if you get troubles with the stomach, for example, rupture or a rupture of an ulcus and the bleeding, you get a hematoma. And the hematoma is filling the bursa or the lesser sac. And, well, regularly it's not a huge cavity, it's a small gap. But the problem over here is that it can be filled, and the stomach will be at the ventral abdominal wall. And if it is filled, the lesser sac, you get 2 liters in there. 2 liters. And then the liquid will search for something where it can go to. And this is, of course, the Morrison pouch. You see? It's not going to the left side. Why? Left, oh no, there is no connection. So it will always go to the right side. Because, of course, you have a foramen over here. Just take a look on that. Where the pencil is now, you get the connection in between number 3 and number 2. You all know this foramen. It's the foramen epiploicum, or epiploic foramen. Nothing else. But this is a very important hole which is used by liquid when the bursa ommentalis is filled. Right side, right way. What about something else? Well, what about the left side? Where's number 4? Collar's pouch. Now that's easy now. You get the collar's pouch just over here. Of course, this would be also collar's pouch. In between the spleen and the kidney of the left side. And you see, the liquid will go just dorsally to the spleen. But what on earth can result that there will be a hematoma or anything else over here? What can be the reason for that? That's also easy. Just take a look on the organ which is on the left side. It's the spleen itself. So traumatology is now on. If you get a trauma of the spleen and a rupturing, it might go into the lesser sac, but it might also go into the renosplenic recess. And then you will see this. Nevertheless, this is systematical anatomy. What about the regular anatomy? Let's take a look again on the images. And this is now the final part. If we go now to the right side. Oops. Here we go. Better? No, not better. No. Ah, that's the way. Ah, no, that's not the way. Like that. Okay. You see two numbers, number 1 over here and number 2. Number 1 is over here the liver. Number 2 is the kidney. And in between there is no gap. Physiologically, there is no gap. If you get a bleeding, if you get a collection of liquid, there will be a hypoechogenic gap in between. And then all the bells are ringing. Alarm, alarm, alarm. That's it. Goddamn, there is liquid in there. Let's go to the left side. So that's Morrison. Morrison is not filled regularly. Let's go to the left side. Number 1, spleen. Number 2, kidney. No gap in between. Again, physiologically, no gap. If there is a gap, hypoechogenic, again, bells are ringing. You have to take care. The problem with somebody who is entering as a trauma patient might be no liquid in there at the first investigation. Always take a second or third look on it, not 2 minutes after, but the next day. Or during the night, might be also. Because if the bleeding starts a little bit later on, because it's just a covered rupture, and then the bleeding is increasing, you get it, let's say 20 hours later, after the trauma happened. So always take this into account too. So you see, all the 3 topics what we focused on, heart, pelvic area, abdomen, is not easy because what you learned regularly is more systematical anatomy, and this is much more. This is a combined anatomy, which is systematic anatomy, topographical anatomy, and section anatomy. So it's now on your turn to go back also a little bit to the textbooks. If possible, go back also to the departments of anatomy. Go back to the different specimens, what you get, and try to imagine how the sections are formed. With that, you will be able to understand all the sectioning, what you can train now outside, or not today, of course, but the next days. Really use this knowledge, not only this little approach to anatomy and to sonar anatomy. Sonar anatomy is very difficult on the very first beginning because you get an image which you have to interpret. If you do not understand the anatomy, you are lost. And that's the problem for everybody, not only for you. Myself, when I started with that, I said, God damn, that's not manageable. It is manageable, but you need a lot of experience. So in your training now, start. If you go to a hospital, if you work over there practically here, everybody who's entering, if it's possible for you, abdominal ultrasound, boof. You are the first one investigating the patient as much as possible, and then call the doctor later on. Yeah? But try it, use it, get your manual skills, get your impressions, get your experience for that. Ultrasound will be the device of investigation of the next years. It's your chance now to get the first step into it. So thank you very much for your attention.
Thanks a lot for getting us up
Everybody tired.
Well, I think at 9 p.m. that's fine.
That's
right?
okay.
I
Yeah.
mean, it was definitely not the talk. It's the
Hopefully
time.
not.
I would say at least. Well, thanks for coming today. We'll start tomorrow at 9 a.m. with a lecture from Denzel Mugabe on how to deal with trauma patients. If you've got like any questions about the schedule or anything, just ask a PE teacher on the way out. Well, otherwise, good night and thanks for coming. See you tomorrow. Well, sorry. There's one more small or big thing I forgot. Like all speakers, Mr. Feigl is here in his free time, and we would just like to say thank you for your time with a little greeting from Styria. You know it, I guess, but it will be something new for some other speakers.
Thank you very much indeed. And as I can promise you, everything is very healthy. So it's honey, it's wonderful.
Well,
apples. We could use this also for ultrasound.
Yeah, I haven't ultrasounded an apple yet, but yeah.
Thank you very much. And I want to say I really appreciate this because it's a wonderful opportunity for you to train this. When you take a look in our, let's say, curriculum, it's more or less embarrassing that no ultrasound is introduced yet. Anyway, the vice rector was over here, Professor Lang-Leudold. Hopefully she really understands the need for that we introduce this as for everybody, not only for you, but really for all students in Graz, and that we can start with an education, a new curriculum, a little bit, let's say like a module on ultrasound anatomy, also with the clinicians together, that we get more experienced at all.
Well, that's...
So thank you again, and
that's
train it.
Definitely quite bold words. Thank you a lot, and yeah, have a good night. Danke. War super. Ja. Das war echt... Das hat passt.